So, good evening, everyone. Once again, welcome to the second session of the program. And as I had mentioned in the group, the topic is developing communication competencies. Some of you may find this session as very basic because a lot of us communicate very effectively. But at the same time, you will find it useful, one, because this session is going to have a lot of activities and experiential opportunities where we'll get to see that we think we communicate well, but how, we miss on the finer details. That is one thing. And also, this is one area where you must be struggling with your staff members in terms of their behavior with patients and their families, and also between healthcare professionals. So this will give you a lot of food for thought, and also content for organizing training programs for your healthcare professionals, especially towards the end. In case if we will fall short of time, then the part of the session will be covered in session 3, which is basically essential skills in patient handling. So that will give you a fair amount of content and structure to organize one of the basic sessions for your healthcare professionals, where you want to help them learn what is the right way of handling patients and all professional interactions. But the whole session has been designed in a manner where we really get to learn through various pedagogies. And the beauty of this session is that I would like to actually tell you to note down what new pedagogies you learned in this session, in particularly in this session, because I'll be using multiple pedagogies, which maybe you have experienced, but then that will also give you an idea that you can integrate these pedagogies in your programs and your presentation, because that's how you engage adult audience and get their attention and also make them participate. Can I request everyone to have your audio on the mute mode, because there's little sound in between. If you could all mute your device. Yeah, thank you so much. Yeah. So before going further, I would like to show you 2 videos. So these videos are done by Indian doctors, so you will really be able to relate with the videos. And though these videos have been done by doctor, and the whole interaction basically shows the doctor-patient communication, but I think this is equally applicable to any communication, be it with the nurse or with the front desk staff or anybody who is handling patient interaction. In the videos, what I want basically from all of you is to kindly note down what you observe which is not appropriate, what you think is not the right thing. I want you to note down, and then I'll ask you to write on the whiteboard. So we are going to learn how to use whiteboard in Zoom session. Maybe some of you already are using it, but that's an interesting way of getting answers. Like chat box, you get to use a whiteboard. So we'll be using that in today's session. But let me quickly show you the video, and then we have the discussion going. Give me a second to share my screen.
Next. What? Doctor, my leg is swollen and painful. Since when? For the last 5-6 days. What were you doing? Why did you wait so long? This looks pretty bad. Doctor, I thought the pain was just a strain in the leg.
Anyway, what do you think now? You could have waited for some more time and we could have amputated your leg. Leave it. What's your sugar level?
It is under control, doctor. The fasting was 140.
When was it done? What was your HbA1c?
It was 4-5 months ago. Actually, HbA1c is a expensive test and I was feeling all right. So,
I can't understand. You do investigation according to your will. You don't take proper treatment. You don't follow our advice. I don't know why you need doctors. And you come up with all sorts of complications like this. And what did you do with your leg?
I went on a pilgrimage to Sabrimala, so had to walk barefoot. I might have injured, I think.
Barefoot? Hello? Yeah. Who? The patient Ram. HIV positive patient. So he doesn't want CT scan. So tell him if he wants treatment, he needs to undergo CT scan. Right, what does he think of himself, yeah? Prime Minister or President? See, discharge him against medical advice and tell him not to come to this hospital once again. Okay? Yeah, bye. And you got this boon. I'll tell you, if you go once again, you will also go near the God. Didn't I tell you about the foot care when you came last time? Huh? And your smoking is continuing without interruption, I guess.
I have reduced a lot, doctor. I am smoking only 1 or 2 cigarettes a day now.
Can't understand your attitude here. You do smoking, you are overweight, you don't take medications, you don't do investigations. I don't know what to tell you.
I'm trying, doctor. And if you don't want to see me, I could consult someone else.
See, whatever I'm telling is for your good. I don't know how to tell. I gave you information leaflets last time and you're not following my advice. And if you don't want to see me, it's fine with me. I have got enough work to do. I've got enough patients to see. Sister, please call the next patient.
Okay. So I don't think in corporate hospitals we would talk like this. Isn't it? No. We'll talk about that later, but first I want to know from all of you, what do you think was inappropriate? And I'm going to open the whiteboard and I want you to write on the whiteboard.
And what is your question? Your question, repeat the question, please.
My question is, what do you think? Is it visible? Is the whiteboard visible to all?
No. Yeah.
Okay.
It's loading. Yeah.
Yeah. So my question to all of you is, what do you think was inappropriate in terms of the doctor's behavior in this video? So somebody is writing, okay. No greetings. Okay. Dr. Mariam is writing no greetings. Okay. Okay. I think can you type and write instead of writing directly? If you type and write, that will be better, isn't it? Because that way, otherwise we will not be able to. Yeah, you could use T. Yeah.
Which one, ma'am? Which one?
There's a T with that means you can use yeah. I think
T.
Yeah.
T.
Yeah. Right. If you click on T and then type, then you will be able to. Yeah.
Sorry. Can I write in the chat room? Because I'm not able to do T.
Okay, no problem. You can verbally say if you have something to say. So
yeah,
some of you just 1 second. Let everybody be over. Then okay. Somebody has written no greetings, no introduction, no smile. did not ask patient to sit down, was very sarcastic to the patient, did not maintain patient's confidentiality. Yes, no smile, no eye contact, no empathy, no privacy of other patient. Absolutely right. And then insensitive, somebody has written. Okay, great, very good. No eye contact. Absolutely right. And then what more? Okay. Bad body. Okay. Dr. Bide is writing something. Would you like to unmute and speak, Dr. Bide?
The body language was very bad. He was very aggressive.
Bad body language. Okay. Now he gets it.
And
Can I?
sarcasm was
Can I?
there.
Because
Yeah.
And he did not pay any attention to the emotions. The patient was pretty upset at the end of it.
Yeah.
So in place of the incident, I got a lot of time and I don't have any time for you people.
Absolutely.
And right from the beginning itself, he was very abusive and and history
Disrespect.
also he interrupted very soon. He
Yeah.
did not allow the patient to complete and he did not ask any more other complaints are there. So
Absolutely.
Madam, another thing you cannot
Yeah.
utter about HIV positive patient in front of
Yes.
any other patient. It is
Yes.
very, confidential, which he's already told in
Yeah.
front of some other patient. It should not be.
Absolutely. So that means patient's information should not be shared and talked
Should not be
loosely.
shared
Like,
and disclosed.
absolutely. So bad behavior. Anas has written bad behavior, and then constant blaming the patients for not being responsible. Absolutely. Should I close the whiteboard if everybody is done?
Yes.
Okay, yeah. So that we can now. Okay. Thank you for participating. I think all of you identified almost everything. Anything that was not there, if somebody would like to point out something that was not there, was not written in the comment or chat box.
Madam, the doctor
Attending
should
to
be
other-
very. No, first of all, my observation was that, see, being a doctor, the
Nivedita, listen to my question, please. Listen to my question. See, this is a communication program. You have to be 100% attentive to understand what my question is. Anything that you think we missed to identify, like all of you have written, behavior was unempathetic, did not make eye contact, did not offer place to sit, he was rude, he was aggressive. Something which was very important,
Hello.
we have missed on.
Hello.
Ma'am, was attending to another call. He was
Raise your
attending to
virtual
another
hand. I
call
request,
in front of the patient.
hold on. Please raise your virtual hand. It will be good if you raise your virtual hand, and then I would know who wants to say something. Okay, Neha actually start. Neha, you can go on. Yeah, go ahead. Yeah, and then Bobby. Yeah.
Basically, he talks badly of an other patient in front of him.
I think that point is covered. Patient's information
And
was
another
not.
thing, the last remark he made is, "I have enough work. I don't need you." That kind of feeling he was.
That attitude was a very uncalled for. Absolutely. Okay, thank you. Jayapriya, yes, you have raised your hand. Go ahead. Yeah.
At the outset, I don't know if he's even identified the name or recognized or greeted the patient at all.
Okay. I mean, I would assume that he was holding patient's case sheet and he was probably looking at the patient's case sheet. So I assume that maybe that was, but maybe yes, even that was not clarified. That was not checked. Absolutely. Dr. Siyog has raised his hand, and then
he has in the past he has given a pamphlet to him. Which he had not explained it to him probably, and he was annoyed with that he has not referred to that pamphlet. Yes.
Okay, maybe that's also true that he gave the pamphlet last time, but probably he did not explain to the patient. Dr. Bide, you wish to say something, and then
interruption by the phone call is not welcome.
Again, see, we say so, but then don't we really get to receive calls, and don't we take calls? Because especially if it is about a patient, we normally can't help it. We have to take. But then do we practice those basic courtesies? Do we practice those basic courtesies where we tell the patient, "I'm sorry, I need to take this call," or "Can you please wait? Like it's urgent, I need to attend." I mean, even that kind of courtesy would be good enough. Seema ji, yes, you wish to say something. Go ahead.
Ma'am, first of all, the self-introduction should be there, and the doctor should ask her open-ended questions.
Seema ji, hold on. we assume that this patient has interacted earlier with the doctor. So we don't expect when we meet the patient for the second visit, we would give introduction or take introduction. Point taken, but then I assume that it was probably a follow-up kind of this thing. One observation that I want to bring in here to everybody's this thing is, of course, you all identified that he made sarcastic comments on the patient's overall behavior. And then he also talked about the other patient's HIV status, which is not, called for. He made mockery of patients' religious beliefs.
Yeah.
If you observe, the patient had gone barefooted, and there are, cultures where people do such kind of, act for some prayer or something. We can tell the patient beforehand. We can tell the patient after the patient has done it that this is the likelihood of the harm that you have caused to yourself because of what you did. But making mockery of patients' religious belief is not a right professional way of communicating with the patient. I think rest of the things you all identified very well, that his behavior was rude, unempathetic, he was not respectful, he did not make proper eye contact, he did not even offer the place to sit. And overall, his overall behavior was, very disrespectful and intimidating to the patient. Now, I want to ask you a question. I'm sure, most of you are working in corporate hospitals, so you would not talk rude like this. Dr. Mehul, do you agree with me? Never. I know, never.
Completely agree.
Okay. But when you don't like patient's behavior, especially when the patient has not complied, or the patient does not come for regular follow-up, patient does not take treatment properly, a patient does not comply with your advice, how do you, in what different way do you communicate your displeasure to the patient?
I would probably make one thing very clear, that these are the mistakes that the patient has done, put forward a fact file to the patient, and then leave it on to the patient to understand that the one who's going to be the sufferer is going to be the patient, and explain it to him in that same point itself by telling them that, look, this is exactly what I have been trying to explain it to you. We have now moved on, and we are probably facing the consequences of the same. It's on to you whether you would like to continue. I would be very clear with him. If you would like to continue with my management, I would be happy if you would like to take any of my colleagues' opinion. And here I would rather use this, this fever between patients that keeps on going on by taking second opinions. It's become like a plague where they keep on taking second opinions, and now Dr. Google is the second opinion person. So I use that to my favor by putting it that it's okay if I have one less patient, but at least I'm happy that that person is listening to me and following what I'm saying rather than me being the one.
So what is this thought process, Dr. Mehul? We have talked about communication a lot of time. Although others may not be on the same page, but I want to highlight here the way you said, I'm okay with one less patient, but it's better if you go and, get somebody else. What communication style it is?
We are also worried about.
Priyanka wants to answer. Priyanka, answer. What do you think?
Passive aggressive?
Exactly. This is passive aggressive communication. This is not assertion.
Okay.
Please remember, everybody, when you think like this inside, even if you are not verbalizing, you are already thinking, and it might come out at any point of time. I would say, see, this is the harm that has happened because we did this. When we say we, I'm with my patient. I'm not saying you did it. The moment I say you did it, that means you have done a mistake and you are responsible for it. Sure. I would say, see, this is what we have done, and this is the consequences of that. And now we will have to see how we go ahead with it. And there are chances that this might turn into, more infection or more problem. That time will tell us. But then this is the situation now we are facing.
मुझे भी जाना है.
Can you please put your device on mute mode? Can I request everyone to put your, yeah. So that's the whole thing I wish to communicate. Passive aggressive is the way you would normally take when you are in a corporate setup, because there you can't be aggressive. So friends, we will be talking at length about communication styles in one of these sessions, and you will get to learn your own communication style first of all. And then you will also get to learn what is the right way of handling that situation, because this situation day in day out you are facing, when people will not listen to you, they will not follow your instruction, they will not come for follow, and you will be frustrated with that. But then how do you really think in a right manner, and then how do you communicate in a right manner? That is something also one of the objective of this program, that we learn how do you really correct create right thoughts and right communication. So passive communication or passive aggressive communication is not okay. Okay, in the same situation, I want to ask you, what do you think the patient, when the patient was interacting with the doctor, and also when he saw the doctor talking about the other patient about the HIV status, and then what does he think of himself? Is he the president or what do you think normally the patient would be thinking in his mind? I just want any one of you to answer this. Raise your hand. Only one person who would raise first would get the chance to speak. Okay, Priyanka, go ahead.
So when we talk ill about one patient or person on phone in front of another person, so the patient will think that we are doing the same about them also. Like, even their information is not confidential, and we are also not respecting them. We are talking ill of the other patient, and this is the wrong attitude of the doctor. So before you telling the patient that you can change the doctor, they will change you. And it's that whole thing about communication is, of course, whether you're working in a government or a corporate or any kind of setup, with the medical legal issues and nowadays the sort of all the complaints hanging, most of us have developed this attitude, whether we want or we don't, that okay, if a patient is listening to me compliant, I will go all out and help them. But if somebody is not compliant, I am happy that patient doesn't come to me. So like, even Mehul said, it will just happen that automatically you will be feeling that let this person not come back again to me, because you're scared of all the problems, because there's a lot of patient blaming also going on, that you didn't tell me, you didn't advise, and things like
Absolutely. We will talk about this also in one of these sessions, that what are the ways to bring about compliance and what can be done, as a part of communication, where you can at least try for compliance, counsel them, and also document what you communicate so that you are safe. Mariam, you wish to say something? Go ahead.
Yeah, praising the things that he has done will help to be.
Mariam, your volume is very low. Audio volume is very low.
Then praising the person for what he has done helps to be compliant.
Can?
Praising the client for what he has done.
You're right. I think you had also written in your comments that he did not praise the patient. And yes, encouraging the patient for the lifestyle changes that the patient is making is also one of the very good ways to bring the patient, to follow the regime. Yeah, definitely. Thank you. So now I am going to show you the second video. Could he have communicated in this manner? And let's see how that exactly happens. Yeah.
Next. Hello, Mr. Kannan. How are you? Please take your seat.
Thank you.
What can I do for you?
Doctor, I think I have a problem with my leg.
What happened?
4-5 days back, I went to Sabrimala and I had to walk barefoot for some distance. I'm very scared now because my leg is swollen and painful in the last 4-5 days. And I think I did a stupid thing by walking barefoot?
Let's see what we can do. Good that you realize the importance of foot care. Meanwhile, how are your sugars?
Actually, my fasting sugars was 140, but it was some months ago. I was feeling all right and I didn't do the HbA1c. It is so expensive, you know.
It is expensive indeed, but it is so important to get the investigations prescribed by the doctors because otherwise it's very difficult to give the treatment, you know, and treatment may not work as well. Anyway, can I examine your leg?
Yeah, sure. Sorry, sir, it was my mistake. I didn't do the test.
Hello? Yeah? Yeah. Excuse me for a moment. Yeah. What's the name of the patient? So he doesn't want the CT scan, right? Yeah. Try to explain to him the importance of CT scan. Yeah, when I come for rounds, I will also tell him. Okay, thanks for informing. Thanks, bye. Sorry about that. You got infection in your leg. So how are we doing regarding the quitting the smoking?
Regarding smoking, it's doing good. Actually, I brought it down to only 1 or 2 cigarettes per day now, doctor.
That's good. But total quitting is very important. See, if you have reduced from 1 pack to 1 or 2 cigarettes per day, quitting that is also not very difficult, you know. And how are we doing regarding the exercise?
Yeah, going on, but I must admit, not so regular.
See, exercise and diet are as important as your medicines, if not more. But for the time being, you need admission for sugar control and control of this infection. Is it okay with you?
Whatever you say, doctor, you have to cure me this time, and hereafter I will definitely take care of myself. This will not happen again.
Yeah, we need to control your sugars and control the infection. Otherwise, it may go for gangrene and may lead to further complications. Now, the sister will go through the procedure and admission process. Okay, and meanwhile, you have this leaflet and we can go through it, which will help you to follow the regimes. Okay, thank you very much.
Thank you so much, doctor. It was so kind of you.
You're welcome. Thank you.
So I hope this video gives us some idea about how the whole conversation can be done in a more professional and effective manner. Satyapal says it is totally opposite of what he did. Yes, and that's what is required. Wherever we are, whether we are on the front desk, whether we are the clinician or whichever department we are in, I think we all have to act very responsible, very professional in our communication. You will come across patients who would not comply. Any idea what is the compliance rate across the world? Write in the chat box. What do you think is the compliance rate across the world? Because you may think it is in India that the compliance is very poor. People don't listen, they don't take treatment seriously, they don't come for follow-up. Dr. Priyanka says 10%. What do others say? 30%, 50%. It's approximately 30%, 35%. So across the world, that's the trend. Patients would not take treatment seriously. They would not come for follow-up. They will not take their medicines regularly. A lot of time, they don't know the importance of regular follow-up or regular treatment or coming for a repeat checkup. And especially if we haven't explained them well, they would not know what lifestyle changes they need to make, what dietary changes they need to make. So there will be lapses in what they do and what we expect them to do. So we don't have to be unhappy about the fact that Indians are not very good, they don't follow the regime very carefully. So I think these 2 videos gave us an idea about what is the right way of conducting yourself. Now coming to the topic of discussion, because that's from where we will further hold our discussion. Any idea what percentage of your personal and professional success comes from your communication and interpersonal skills? I repeat my question. What percentage of your personal and professional success comes from your communication and interpersonal skills? Seemaji says 80, Mariam says 80, Bobby says 90, 70 to 80. Excellent. 90, very good. A study by Harvard says 85% of your personal and professional success comes from your communication and interpersonal skills. Most of you are well placed now. I would ask you to reflect on your college days. Try to recollect your friends who were with you and see where they are. Those who had good communication and interpersonal skills, where they are, and those who are mostly quiet, not very vocal, not very, expressive, not really participating, where they are. I think it clearly tells us that mostly exceptions are always there. We see people changing and completely transforming after working on themselves. That's true. There is no doubt about it. But mostly those who don't take communication and interpersonal skills very seriously, and they assume that if I am a clinician and if I can diagnose and treat, that's good enough, which is not true right now. We all know that patients are not happy when you don't really treat them well, and they go and talk ill about us in their system. So in how many ways do we communicate? I want you to write in the chat box. In what different ways do we communicate? So broadly in what? Okay, verbal and non-verbal. Okay. Seemaji says verbal. Bobby also says verbal and non-verbal. And what all does come in non-verbal communication? Okay, eye contact, smile, body language. Okay, broadly. Okay, eye contact, body language. Okay, so you are very right. There are two broad ways, that is verbal and non-verbal. And the non-verbal covers your paralanguage, that is tone of voice, pitch, volume, speed, all that is part of non-verbal. And of course, your body language, which includes your smile, posture, gesture, everything. We are going to talk about that. Written is again verbal, though it's in the written form, but then it is like words, it is use of words. So it is part of the verbal communication. Last question, and then I start with my presentation. What percentage of communication happens through spoken words? What percentage through your body language? And what percentage through your paralanguage? Guess. Okay, Mariam says 80-20. So 80 is what, Mariam? Dr. Priyanka says 70% verbal. Seema also says, Seema ji says 70% non-verbal. Okay, Mariam says non-verbal 80%. What about others? Dr. Suyog, Anas, Satyapal, majority non-verbal. Okay, 40% verbal. Okay, it's what a person feels after a consultation that brings them back. Okay, 40 verbal, 40 non-verbal, 10 para. Okay, good attempt. 90% non-verbal, 60% non-verbal. You will be surprised to know that according to Dr. Albert Mehrabian's theory, only 7% of the communication happens through words. 93% is non-verbal, and in that 55% is your body language and 38% is your tone of voice. So imagine your words and your tone of voice have 45% of the impact, and 55% is your body language.
Ma'am, can you repeat that, please?
Okay, only 7% of the communication happens through words. I'm going to show you a slide also on this. Yeah, only 7% of the communication happens through words. 38% is your paralanguage, that is quality of your voice, tone, volume, speed, everything. And then 55% is your body language. Let me show you the presentation so that you can simultaneously look at the slides and where are we? Give me a second. Where is the slide? So this we have talked about, that 85% of our success comes from our communication and interpersonal skills. So this is the slide I wanted to show you, that only 7% of the communication happens through words. 38% is your intonation and 55% is your body language. Now, if I may ask you here, do you think words matter? Do you think words matter? Yes or no?
Yes, they do. Yeah.
They do matter. So we'll do a small activity to understand, see how words that we use that can completely change the communication and the energy that we carry along with us. So I want 5 people to stay in the main area, and rest can just switch off their video. You are there, you will be able to see the whole activity, but I want you to switch off your video. So maybe, I will at random say who all 5. Mariam, you can stay. Jayapriya, you can say. Dr. Biday, you can say. Bobby, you can say. Nivedita ji, you can stay if you're comfortable. Rest all can switch off your cameras for few minutes for the activity. Neha ji, you can switch off. Satyapal, you can switch off your video. Anas, video अपनी off कर लीजिए. Thank you. Okay, so we are 6 of us. So imagine that we are going for a camp, health checkup camp. We are planning a health checkup camp from our hospital side in a neighborhood area. So we are discussing about the health checkup camp, and every time we will start, like each one of you, when you will start talking, you will start like this. I'm okay with the plan of health checkup camp, but okay, I will make the beginning, and then I'll pass the baton to the next person, and then you can continue. So I'm okay with the plan of health checkup camp, but I don't think that area has enough number of people staying in that area. Okay, Dr. Praveen Biday, what do you say? Unmute your device, sir, and start with the same. I'm okay with the plan, but
I'm okay with the plan of health checkup. However, I feel that we will not be able to complete the checkup because there are huge number of patients. We may have to go multiple times.
Okay, but I don't think we will be able to cover everyone. Thank you. Yeah, thank you. Yes, Jayapriya.
I'm okay with the plan of health checkup, but I don't think we will have enough privacy in the place that we're going to be able to examine female patients. So I think we should make alternative arrangements.
Okay. Nivedita.
I'm okay with the plan, but I think the further it will not increase our footfall in the hospital.
I agree. Okay, Bobby, go ahead, please. Unmute your device, Bobby.
I'm okay with the health checkup camp, but I think that doesn't come under the area of our hospital, which is very far away, and it may be difficult for the patients to be referred to our hospital.
I agree. Okay. Yes, Mariam, what do you say? Please unmute your device and speak. Yes.
All the reasons everybody has taken, so I don't have any.
I don't have enough number of people to go with me from my department. Anything, but does not require any reasons. It requires excuses.
I'm okay with the plan of health checkup.
Hmm.
I don't think we'll be able to cover a lot of things.
Agreed. Okay. Now we are going to
Actually,
have
I was about to tell what you said, Dr. Indu, that I don't have enough staff to go with me for the camp. I was thinking, but then you said that.
as I said, excuses. I mean, there are ample. We don't require any genuine reason to give excuses. Now we are going for the second round of discussion. But we are going to replace this word but. Instead of but, we will use and. I'm okay with the plan of health checkup camp and. Hmm? I'm okay with the plan of health checkup camp, and I will make sure that we have, community support. I will go and speak to the community leaders, and I'll ask them to provide as many, facilities and resources available to make sure that the camp goes well. Yes, Dr. Bide.
I'm okay with the plan of the health checkup camp, and I would like that we should advertise it properly beforehand so that the maximum number of people can attend the checkup camp.
Point taken. Thank you. Yes, Jayapriya.
I am okay with this plan of health checkup, and I think we should take measures to be able to take care of the female crowd that is going to come.
We can make arrangements. We can have some covered area for their examination. I understand your concern because you had pointed out that we may have difficulty examining them. So we can definitely have some cordoned area where we can do the examination. Thank you for that. Yes, Nivedita.
I'm okay with the plan, and we should also make sure the staff which I'm going to send, they should be also, feel comfort over there, because many camps we cannot do that thing, and staff cannot examine properly due to crowd and all. That should be segregated.
Yeah, we can
area should be segregated.
We can make proper. Yeah, we can do that. Yes. Yes, Bobby. What do you say? Please unmute.
I'm okay with this health checkup camp. And I also feel that in this camp, we must also advertise about adult immunization, and we should carry enough flyers and, education materials to distribute.
We can include that. Immunization can be a real good reason for people to walk in, because when they know they are going to get some additional service, they'll be happy to come. Thank you, Bobby. I think that was a very good point taken care of. Yes. Yes, Mariam.
Thank you.
I'm okay with the plan, and we can involve the community as like volunteers.
We can include them, yes, because they can help us get things that we require to run the show. Thank you so much. Thank you. I think we had a wonderful discussion and we got a lot of good points from all of you. Can I request all the members to have your cameras on? I would request some of you to unmute and share your observation briefly.
Ma'am, the one word makes a huge difference, like but and end. The but is the negative, and the end creates a lot of the opportunities of growth and something. So one word can make the changes.
Wonderful.
So the word,
it's a very good observation, Seemaji. Thank you. What do others say? What is your observation? Something different from Seemaji. Please add something different from what.
It's again the mindset in communication as a team. When you want to do something together successfully, then there are no buts. There are only ands, and everyone is working together and finding out the solutions. But when the team is not interested in doing something together, they are all making the excuse, and then nothing happens.
Wonderful. Very good observation. Somebody else who want to add to what Seemaji and Priyanka ji has talked? You will always find people ready to mirror you. If you start with but, you will get lot of buts. If you start with and, you can change the energy. So rather than pointing at others, I would say work on yourself and see, are you using a lot of ifs and buts? If you are doing it, then you are not creating the right energy. Be it with the patient, be it with your family member, be it your fellow professionals. So check, other than this if and but, what other words are you using in your communication that you think creates negative energy or does not create good, healthy communication environment. Write in that chat box that one word that you think you see, you use or you see people using for others, and that you think could be very, very detrimental to communication. Sometimes with juniors, we do that. Sometimes with patients, we do that. Write in the chat box. Waiting for the ideal world. Yes. It may not be possible. It may not happen. This cannot happen. This is also very commonly we get to hear. This is not possible. This is another word we get to hear. Are you in your senses? Again, when you say something like, do you think the other person will be encouraged to talk? I think. You always do this. Yes. You never listen to me. You're never on time. You always act very irresponsible. So when you give such generalized comments to your fellow professionals, they would believe that you have already made up your mind about them. Again, not a very, okay. Then we try to show them their negative point. Yes, obviously, I think that's what one of the errors we all do. And that's something that really breaks down the communication. I cannot, or we cannot do this or that, as this or that is not available. That means, again, what we are saying, we are saying that because these things are not available, so this is not possible. So you see, a lot of us use these ways of creating hurdles. Unknowingly, we are creating hurdles in communication, in interaction, in rapport building, in progress. So words, although we said only 7% of the communication happens through words, but then you create resistance. So please also remember at the same time, if you will use right words, we all like to mirror each other. If you want to change the energy, start demonstrating. The best way to change people behavior is role model that behavior as much as you can, so that people observe, identify, and then try to mirror that. That requires a lot of patience. We usually become impatient and we say it's not happening, it's not occurring. But you will see mirroring has a very, very huge role in the way people interact with us. If you are aggressive, the other party will become aggressive. But if you are not aggressive, the other person will automatically start realizing that this person is not acting aggressive, so I don't have to be aggressive. So that's about, the power of words. And then coming to the language part, going little more further, activity we have done, going little further, these, you can think of some common errors we make while, communicating with patients or with our juniors especially. So a lot of time we use the words tu. I don't know how many of you are familiar with exact Hindi. Tu kar le, tu chala ja, tu chali ja. Especially when the person is a junior or is, if we talk about position wise, that person is, positioned less than us in the system. So we do use such words which are little, disrespectful for them, and they don't like it. So common errors that you would see people making is that they will use disrespectful language, especially with, younger staff, and also people who are, in the system who hold a lower position than you. We also become rude, authoritative, and uncourteous the moment the other person does not agree with us or does not comply with us. That's because we become aggressive with others. We also snub others by using foul language, especially when we know that I can use this style with the person who cannot, give back or who cannot resist. And then we also forget to use basic courtesies. Like, for example, we receive phone call. How many of us actually say, I'm sorry, I need to take this call to your patient? Or you make your patients wait and you are genuinely busy somewhere. You come back and before you actually start, working with your patient, you say, I'm really sorry you had to wait, but that was something very urgent and I needed to be there. So these are all basic courtesies which we need to use with each and every person that we interact. But a lot of time we don't use this, or we don't demonstrate this, because we don't consider patients as equal to us, especially in a setup where the patient is not very educated or is from not a very well-to-do background. So there we have all the more tendency to be disrespectful, and then sometimes we become rude in the name of being assertive. We'll talk about assertion in length. I think we'll understand it more. Yes, Mariam, you wish to say something or ask something? Go ahead. Unmute your device.
Should we say uh, sorry, I'm late, or should we say thank you for waiting? Which one would be better?
Mariam, I couldn't understand. I'm sorry. I think your voice is not really clearly audible.
She's saying, should we say sorry, I was late, or thank you for waiting? Is that correct, Mariam?
Absolutely.
Yes.
Instead of saying sorry, can we say thank you for waiting? So yeah, it's the play of words.
Usually when you give them a reason, and which is very genuine, they feel at least that we understand that we have made them wait and we value their time. So when you say, I'm sorry you had to wait, but I was, busy with another patient, or there was an emergency and I had to be there, patients would normally, say, what will they say?
Madam?
What will they say normally? Nivedita, you want to answer?
Yeah. Ma'am, one thing what I want to say, that this type of communication actually we learn from customer care, because whatever we say, how aggressive we are, customer cares always give a positive answer. Sorry, ma'am. Thank you, ma'am. Whatever it comes out. So, ma'am, in my professional life, I have learned from the customer care division only how they react on the aggressiveness.
But not all customer care people are that polite. But yes, if they are polite, that's a wonderful way to establish communication and also calm down the other person. But even if you say thank you for waiting, even that's okay, Mariam. But usually when you say sorry, you had to wait, but I was really, occupied. When you give them little explanation, they are more satisfied with your answer. That's the whole idea. But I mean, there's no one line answer that no, this is how you have to communicate. You can evaluate what works in which situations, and that's perfectly all right. At least as long as you're acknowledging that they have waited for you, that's good enough. That's good enough. Another problem when we are communicating with patient is the way we communicate, the way we explain to them. So I'm going to show you a paragraph, and I want all of you to read this paragraph with me, to yourself, not to.
Madam, you are a bit fast, ma'am. थोड़ा slow चले.
This is not exactly.
I am having eyesight problem also little bit.
There is sound combustion, rust oxide, carbon dioxide, oxygen.
It was a deliberate act of not letting you read. Because I wanted to demonstrate that when you explain to your patients and when you are using technical jargon, they don't understand much. Studies have shown that almost 50% of the patients and the families have reported that they don't understand much when they're explained about their diagnosis, treatment, intervention, prognosis. Because the vocabulary that we use is not, fit for that conversation with a non-medical person. But we don't get to realize. And we use such words which they don't understand, but they would never say, sorry, I didn't get it. Can you please explain? That's the problem. Yes, Dr. Priyanka, go ahead.
just to add, as part of that's why when I got trained in the UK as part of the Royal College exams, we have very clear-cut sessions on how to manage an angry patient, how not to use a medical jargon, and how to use the simplest language. Again, managing when we break bad news. So these are very structurally explained. Like even when you break bad news, give 10 or 5-second pause. Don't keep on telling what you want to say, and always ask the patient again, am I clear, rather than did you understand? Because am I clear, do you want me to repeat again, which is very important. But in our consultation time of maybe 10-15 minutes, we want to tell so many things together that sometimes they are not, especially when things go wrong or patient is in ICU or there is some unexpected complication. So that's very important.
So to your this point that you have brought in here, the whole idea of communication programs in India came in from England, from UK actually, because people who have worked under NHS, when they came to India, they realized that there's no training at all. And I think the initial training was conducted like these two people whom you saw in the video. They are from Bangalore Baptist Hospital, and they are the one who actually initiated communication program, master trainer program way back in, I think, 2011 or 12. That was when they started, and I'm one of the person who was trained under them. But then incidentally I took it forward in a manner, then and I modified it and I kind of changed the thing. And all that what you said we are going to cover in the program. How do you handle aggressive patient party, how do you handle complaints, and then how do you break bad news, and then how do you disclose medical error. That's the idea, that each one of us should learn it in a structured manner so that we can do it and also train our people. So what you are saying, that when you talk and when you don't listen, definitely they don't understand much, but they will not ever raise their hand and they'll say, I don't understand, can you please explain me again. Very common, you will get to see. Mariam, you wish to say something? Okay, so when you are explaining to your patients or their attendants, couple of things if you can keep in mind that will help you in making your communication more effective. First thing, please check for any language barrier. Any idea how many languages we have in our country? Write in the chat box. How many languages do we have in our country? Official languages. Official languages are 20. 22, I'm so sorry, 22 official languages. And how many dialects we have? More than 700. More than 700. So you can well imagine that you can expect patients from any part of the country. And now, why only country? I think India is becoming a hub for medical tourism. We are getting patients from neighboring countries and also far off countries. Incidentally, we have apps to translate their language. We have translators who would do this job for us. We have people who know both the languages who would, work, do the licensing work. But we do not have many apps to translate our local Indian languages. And we don't even care to hire people who can translate for us the languages from Northern India or Southern India or Northeast state. But if you are able to check for any language barrier and address it promptly by having somebody who can explain to you, then definitely you will make sure that your communication with your patient is established. When you're talking to them, try to use as simple as clear language as possible, because a lot of times simple words that we use in our regular way, BiPAP. So we know what BiPAP is and what is the difference between BiPAP and CPAP, but patients and their family member may not understand. So we really need to make sure that we use the language that the patient can understand. And one of the thing that we have to remember, one of the ways to overcome these barriers is use of audio-visual aids. So whenever possible, if you use charts, posters, models, drawing, I think one thing that I would recommend to one and all, when you're explaining, especially when you're taking informed consent from your patient, it's a good idea to draw on the case sheet directly when you take consent. For example, if you're explaining the procedure or the condition or the deformity or the process or intervention, if you draw on the case sheet, that itself becomes an evidence that you have explained to the patient, and the patient has been given enough understanding of what is going to be done or what is the condition. But there are so many other ways to help the patient and their family members understand what is being done or what is the status. Rather than just using words, you can use audiovisual aids to explain. Then of course we need to explain do's and don'ts very, very clearly, because a lot of time errors happen when we don't explain them what are the do's and don'ts. And especially when it comes to medication, you will see a lot of errors patient would make at home, because they don't have any idea, they don't have anybody to guide, so they would assume things and they would do that. And then very important thing, that is check for understanding by asking them to repeat what they have understood. The activity that we did in the last session, if somebody had asked the next person, have you understood? And if the other person said yes, and if the first person asked, okay, tell me in your words, what did I say? I think this error could have been avoided. So whenever you are explaining to your patient, especially for example, when the patient is being discharged, you would explain everything. I would ask you to ask your patient, have you understood? They will say yes. Ask them to repeat. Trust me, they will not be able to repeat more than 30 to 40% of what you have explained. But if you will ask, you will get a very clear idea how much clear you were in your explanation. And in case if there's a gap, you can always fill in the gap. Now coming to the, yes, Nivedita, you wish to say something?
Madam, I want to share one thing, that during my daily course of work, we have to counsel the patient with that first of all clinically, and second, the vital point is the financial. Madam, we are, especially I made a rule that we made in a black and white. We have made a counseling form, okay, where financial counseling is done very transparently, starting from bed charges till operation charges, OT charges and all, okay, clearly. And what I taught my staff and all, that when you are explain them in details. If you think that they have understood, still you ask them whether it is not. If they say yes, you say them कहाँ पे रोका हुआ है, आप बताओ कहाँ पे आपको समझ में नहीं आया. Then they read that one, okay. And then another option I say कि ठीक है आपने समझ गए, साइन करो and take the photograph. क्योंकि मैं जब आपको bill place करूँगी, you can see where is the mistake. So that confidence automatically comes to the attender, and believe me, ma'am, within this tenure, we avoid many such things happen, because financially it happens, if when it comes to
that's the bone of contention. That's the major reason for
yes
conflict. Financial.
We try to
transparent, and if you explain them well, and if you give them a chance to ask you a question, they are more than okay with what you're doing. Yes, Dr. Priyanka.
In fact, in certain high-risk cases like liver transplant surgeries, they even have video consent. So patient, the whole family, all the stakeholders are sitting in a room and a video consent is taken where even risk of death, all that has to be communicated. Even when I have a case for surgery, even I try to explain them all the complications, let them be fully satisfied and understood, and then only go ahead. Because sometimes we are a little wary to talk about the complications. And when there is a complication, that's when the problems happen. So it's a very good idea to be very transparent.
I think I completely agree with you. More transparent you are, more confidence they will have in you, and they would believe you more, because you haven't covered up anything, or you haven't not hidden anything from that. Thank you for bringing that up. Now coming to the written communication. See, in healthcare, I think written communication again plays a very big role. I think in most of the corporate hospitals, we have now, everything on the computer, I believe. So there is less likelihood of any error because of at least spelling mistakes or, other kind of error. But in a lot of hospitals, still we are practicing handwritten notes. So I'm just sharing a couple of handwritten notes with you. This is one of the resident in the gynae, department, recent notes. So you can see, I think Priyanka can understand, or some other, some of you who are familiar with the common vocabulary that you use, you would understand. But honestly, it's so very difficult to, actually understand what exactly it is. But this is another sample for all of you to see, another, notes written by the resident, and you can well see what exactly is missing in this. If you can quickly have a look at the sample document.
Usually we should write in the SOAP format, the subjective, objective, assessment, and then the plan. And again, is all in running case, and it's
absolutely. And
Madam, as per NABH, you cannot write medicine in running letter. It should be in block letter.
Agreed. What do others say? Where are others? Everybody's sleeping except Priyanka and Nivedita. Bobby, get up.
Lama summary and
चाय पियो भाई, पानी वानी पियो. क्या मिसिंग है इस स्लाइड में? पेशेंट का नाम ही नहीं है.
There is no
demographical details नहीं है पेशेंट की. Imagine we are writing no stamp and signature. Yes. Okay. Claim will be rejected. Yes, doctor.
Two identifiers are missing.
This is the government hospitals document, so there is no, risk of claim and rejection. But imagine
no UHID number,
no
identification number,
no demographical details.
And even who has written the summary also.
Exactly.
Even the restricted abbreviations are
now
used.
I think you're all making up, and you can see, and these kind of documents you see every day. So write in the chat box, what are the common errors you get to notice in the written work? Write in the chat box quickly, everybody.
And these are the places where litigation will happen, where things go wrong, only everything will go wrong.
Absolutely. I think if your written work is not up to the mark, then you are always be ready for problems. Yes. Medication errors, yes. No proper SNDT, yes, agreed. No capital letters, very often we get to see this. Overwriting, yes, absolutely. Illegible handwriting, no date, time, or name of the doctor. Patient identification not there, yes, very common. You will get to see this. Illegible handwriting is another common thing that you get to notice. Two identifiers not being used, I think. Then no stamp, no date, yes. No uppercase, no signature of doctor. I'm not talking about only this document. In general, what common errors do you get to notice? I want you to write that. Normally, we get to see like illegible handwriting is very common. People use abbreviations. That's very common. Paper will not sign, or even if they sign. I was taking a session for a group of residents. I said, why don't you sign properly? Why don't you write your name? One of them said, we are told ki ek chidiya bana diya karo. You don't have to let your name be read. Make a kind of some,
they are not caught, so that they are not caught. That's why.
And do you really think it is difficult to catch anybody? It is not difficult. It takes little effort, and you can identify who has written this document. This is just out of fear, or we believe that I will not be identified. Generic name of the medicine is not written. Okay.
Senior doctors are not setting a good example. Many places I have seen just always a registrar or the junior most is writing the notes.
Absolutely.
And there is no responsibility. So they keep learning that, and that is
that's what becomes their norm for future. I agree with you. So common errors that you will get to notice, in the written work. This is another sample that I'm showing to you. One of the patients who came to me, and this is what the treatment plan written. I've just covered the name because I don't want the name of the patient to be read. Now, common errors that you will get to notice, with the work is handwriting is always a challenge. I think earlier it used to be said the handwriting can only be understood by the pharmacist. But now I think even pharmacists cannot read, because earlier we had only handful of medicines. Today we have so many brands and so many medicines that it's impossible even for any pharmacist to actually exactly be able to identify what medicine it is. I remember my husband is an ophthalmologist. So he had written for a patient all the medicines, and in the end he said, eye care as explained. The chemist gave even some medicine for that also. So abbreviation is another challenge. And also, even if it is a standardized abbreviation, if your patient cannot understand or decipher your abbreviation, there can be an error. You will come across patients, for whom you have written SOS, some medicine and SOS, they will continue taking because they don't know SOS means only for immediate. Or BD, TDS, OD, your patients may not know. So again, such abbreviations are not, really recommended when you are writing for your patient.
Madam, NABH do not allow also.
Yeah.
Yes.
NABH never allows that.
Nivedita ji, but how many hospitals are really following?
Even corporate also do not allow.
Agreed.
Do not do that.
They are just
Consultant
limited
do not
number.
do that.
But what about the government?
Even there, I have seen errors happening.
Yes, in corporate also, madam, I'm fed up of requesting all the consultant, please you don't use like that way. But still they are doing that. RMOs are acting against the
old habits die hard. Old habits die hard. Okay. A lot of time you will get to notice done but not documented. So this one example was shared by one of a gynecologist, a very good friend of mine. She said that in the hospital emergency, a lady came, full term and in labor pain she came, and the resident who was on duty, she said, okay, she wrote in the case sheet magnesium sulfate and then transferred the patient to the gynae emergency. And the nurse or the resident on duty gave magnesium sulfate and the patient was moved to the gynae emergency. Nobody signed or tick marked that this medicine has been given to the patient. Now, when this patient was received by in gynae emergency, whoever received, the doctor or the nurse, she or he thought that we have to give this medicine. The patient received second dose of magnesium sulfate. And you all know what happens when you receive double the dose. Patient went into respiratory distress, was admitted in ICU. With lot of struggle, they could save the mother, but they lost the child. So a lot of time, these kind of errors can cost us a life when you have done something and you don't write it or you don't document. Then you will also come across mistakes where it is documented but actually not done. For example, you have gone to give injection, the patient is not on bed, the patient has gone for some referral or maybe to the washroom or for some activity. You come back, you sign the document thinking, okay, I will do it before I go. But you forget and you get busy with some other assignment. And then you go home. There is an injection lying there or medicine lying there, but nobody knows whose medicine or injection it is. But because on record it is done, so nobody gets to know who is the patient who has not received it. Especially in a large, hospital with a large number of patients, it's very practically impossible to find out who hasn't received the medicine. Yes, Dr. Bidde, please go ahead.
Documented but not done. Another example is the sister sits on the table and writes down the temperature chart, pulse, BP of all the patients without doing it. That is a very common thing we have noticed.
Why only why do we say only for nurses? I think even BP and other things, vital signs that even when junior residents are supposed to check when they are examining the patient, I don't think, everybody does it, especially.
Everybody checks the blood pressure, not the pulse. So even patient in sepsis will have a 80 pulse only. That's the thing.
Yeah, exactly. So you're right. A lot of time they would just write done, but actually it is not done. I completely agree. I agree with you. Yeah. And then this we very often get to notice when document is not signed, dated, and timed. Even in this sample that you can see, it is something like S is written, but I don't know who is this S. And there is no, of course, date is there on the top, but then there's no time and the proper signature and the stamp of the person who has actually written this medicine. And especially if you look at the medicine, this is a patient who has visited a psychiatrist. Imagine the chemist dispensing these medicines to the patient without any proper stamp of the doctor's name. Then language is a barrier, we all know is a problem. There can be, poor writing skills. That's another very big challenge. Not very many people have learned how to write a case sheet. Not very many people have formally learned how to write a reference slip. Not very many people have learned how to really, document any incident. So when it comes to writing, you will see very, very poor, writing skill among a lot of us. I think the following guidelines can help us, to write a good clinical document. For example, one thing if we keep in mind that who is the potential user of the document. If it's a patient's OPD slip, I know the patient is going to go home and use this slip for buying medicines and taking medicines. Then I have to keep in mind it is the patient or their family member who are non-medical who will be using this document. So it has to be written in a manner that the patient can understand, so that it is easy and not any technical. Handwriting, of course, we all know now, wherever possible, we are moving to the typewritten document. We are avoiding, handwritten document. But still, a lot of hospitals, especially the government hospitals, primary health centers, district hospitals, I don't think they still have any facility like typewritten document for the patient. It's usually handwritten document that the patient receives. We should avoid abbreviations, and if needed, only use standardized abbreviation. I would say, especially the document that has to go to the patient should not have any abbreviation, because you never know whether the patient can really decipher the abbreviation. Please don't overwrite. In case if you need to overwrite, just correct it with a single strike and then rewrite, and don't forget to sign it, because if you don't sign it, then nobody will know who has done this correction in the document. Document has to be complete, accurate, precise, and timely. If it is not done on time, it is as good as not done. And then the language has to be very objective, clear, and concise. There are so many protocols available. If you will Google search, we will be going out of the scope of the program, but I think documentation has to be learned formally. People should learn, be it doctors, be it nurses, be it anybody who is handling patients' document, they should learn the right way of writing that document. And there are so many protocols available, like Dr. Priyanka was talking about SOAP, and there are many others. There are many others. If one learns, you can actually write the whole document in a very structured and very objective manner. Now, coming to the language part, we have covered the language part. Now, coming to the para-language part. What is para-language, by the way? What is para-language?
The tone of your speaking.
Exactly. Yeah. Language is words. Para-language is how you speak those words. So para-language is everything that includes your pitch, volume, rate, quality, intonation. So communication is not what you say, but it is how you say. Somebody comes in and I say, Aye. Somebody comes in and I say, Aye. I haven't changed the word, but I changed my tone of voice. I think the whole communication completely changed. And 10% of the conflicts are because of the wrong words. 90% of the conflicts are because of the wrong tone of voice. People can understand our intention and message from our tone of voice. So it's very important to remember that the tone of voice has to be appropriate, professional, and very carefully thought of. Now, I have written one sentence 6 times. Put little emphasis on the word that is underlined and highlighted. You will see the meaning of sentence will change every time. Could you see that? And that's what exactly happens when we are communicating with people. So tone of voice has to be very carefully, put in action. A lot of time when the tone of voice is inappropriate, that itself can be a reason for conflict and aggressive reaction. So what a tone of voice is inappropriate? What do you think? What tone of voice is inappropriate?
Tone of voice, madam, it should be according to the situation.
Okay. But in general, I think in general, we have to remember that if we are sounding unfriendly, there's all possibility. Bobby, are you saying something?
Sarcastic.
Yeah, if you are sarcastic. Yeah, we saw that video and we could see that he was unfriendly and he was sarcastic. Or if you are sounding disinterested and unconcerned. Patient or their family members, when they come saying something or asking something, and if we sound disinterested or not really concerned, they can sense it that we are not really concerned about their welfare. Or in any situation, if they find us inconfident, they will immediately have a doubt that there is something wrong. If you are not sounding confident, they feel either something wrong has happened or something wrong has gone. Or if we are rude and authoritative and aggressive, all these are inappropriate tone of voice. In a professional setup, I think we all have to remember that we have to be professional but friendly. We don't have to be rude, we don't have to be aggressive. Whatever patients or their family member ask for, we cannot show that I'm not interested or I am unconcerned. We have to act responsible. If I don't know the answer, I will have to say, let me find out and come back to you. But I can't say, I don't know, go and find yourself. Confident, because ultimately patient would trust you if you sound confident. And confidence comes from your knowledge, your experience, your practice, and of course, communication skills. You have to be soft and polite, and at the same time, you need to be assertive. There will be situations when you are handling difficult situations, when the patient is not agreeing with you, they are not understanding your point of view. We don't have to be aggressive. We have to be assertive. And we are going to talk about it at length in one of the coming sessions. So don't worry, we will be talking about it. And as I said earlier also, a lot of time inappropriate tone of voice can trigger, extreme reaction and violence. So we have to be very careful when we are handling, especially difficult situations, when we are handling any aggressive patient party. We have to be soft, but at the same time, we should be audible. If you are not audible, again, patient will feel that you are not confident of what you are saying or you are not sure of what you are saying. So we need to learn the art and skill of assertion. By the way, what is assertion? What is your understanding of assertion? Okay. Dr. Priyanka, I want somebody else to answer. I know you would say, but then I want one more person raise the hand. Okay. Neha, go ahead, please.
Assertion is when you are firm for what you want to say. It could be a no, but you are not aggressive, you are firm about it. And you are very polite and though you are being firm.
Okay, polite.
So being assertive is very important in administrative roles rather than being aggressive in tone.
So when you are firm, is that really assertion or it is subtle form of aggression?
No. It is not, you are not aggressive, but you are firm that this is the policy and we really cannot do it. You can be very polite, you can give explanations, what are the issues why you can't do it. But you are firm, this is it. Aisa.
Okay, taken, point taken. What more besides being firm and clear? Yes, Dr. Vijay.
In assertive, you say what you want to say.
Okay.
But at the same time, you are ready to listen to what other person is saying.
Wonderful.
Yeah.
Wonderful. I think being ready to listen is a very good quality if you want the other person to, first of all, feel being heard and also to actually, continue the conversation and come to a point where you are able to create win-win situation. And that will only happen if you are ready to listen to the other person. Dr. CEO, you want to say something?
Yeah. Just to second with Dr. Praveen, it's about, yes, what you want to tell. And at the same time, there is no win-lose situation. There's a win-win situation.
Yeah, absolutely. So you're looking for a way out of the situation where both the parties are happy. And it's not that what I'm saying is the final word, but we can always negotiate and talk about it. Yes. What else? I can see some answers coming in the chat box. Body posture, gesture should be friendly, agreed. Satyapal has written, be polite and friendly. Okay, that's also taken. Seemaji says, assertive is friendly communication. Okay, make eye contact. Mariam says, not passive and aggressive. Absolutely. And then, okay. Okay, I can see one more answer in. Okay. What is that? You're talking about meeting, Mariam? Are you writing meeting? Okay. So if I briefly explain you assertion. See, in assertion 1, you have 5 elements. 1, you're open. You're honest. But at the same time, you are communicating in a positive and respectful manner. You are ready to listen to the other person. You are open to even accepting what they are saying. Maybe when you are discussing with your team and they come up with an idea which you think is more useful or makes more sense, you would not hesitate thinking that, oh, he's my junior or she's my junior, why the hell should I accept her point? I'm the boss, so I'm the one who should be communicating. When you are talking to your patient, when you're negotiating treatment with your patient, you are advising a procedure, but the patient or the patient's family says that this is the reason we can't get it done. You don't get angry about it. You just communicate that this is the need of the hour, this should be done, rest is your call. So you communicate what needs to be done. They agree or not, that's their call. And if they have a valid reason, for example, if there's a marriage in the family or there is some other exigency, you would understand. You said, I understand that these are very genuine reasons why you're not able to, accept the protocol. But I'm going to document it. I'm going to sign it. I want you to sign. But I've explained to you the consequences of not following the vision. And that's all. So in assertion, you don't dictate your terms. So when you say putting your foot down and saying, again, it's a subtle form of aggression. It's not assertion. Yes, Dr. Priyanka, you want to say something? Go ahead.
I think there is no role of being aggressive, whether it is physical or verbal. We have to be assertive, means we don't need like this, the bad communication scenario, the doctors reacting rather than responding. So assertive is you are laying down the benefits, the risks, telling very clearly, very objectively what are the issues involved. But be getting aggressive or has no role. So
absolutely, I think spot on. Yes, exactly. I meant that when you're handling difficult situations, that is where you need to be all the more assertive and be mindful that you don't become aggressive or subtly aggressive. A lot of time we don't think that we are aggressive, but we are actually, maybe our tone of voice will change or our facial expression change. Maybe we won't raise our voice, but then they can see that there's a kind of sternness in our way of communication or displeasure in our communication. That is not assertion. That is absolutely not assertion. But we will be talking about it in length in one of these sessions. And you will also get to know your primary way of communicating. That will be an interesting revelation for all of you. We'll discuss that. Now, coming to the third part of communication, and that is body language. And as I said earlier also, 55% of the communication happens through your body language. What do you see in this picture? The person is?
We didn't hear.
Okay. What do you see in this picture?
He's yelling.
He's yelling. You can make out. Even if you don't get to hear any word, you can make out that he's very angry. He's shouting. He's really annoyed with somebody. That's because you could see from the body language what is his state of mind and communication. Our actions speak louder than words. We think the person is not able to sense what I'm thinking or what is in my mind and heart. But honestly, what you say and what you do, people are able to see the difference. Let's do a small, interesting activity. All of you are with me? Can I request everybody to have your cameras on and sit straight and relaxed? Thank you. So I'm going to ask you to follow me. I'm going to take you to your childhood. I hope you remember that poem. If you're happy and touch your nose. All of you know this? So you have to do it with me. I'll just give you one sample and then you will do it. We'll one practice session and then we'll actually do the activity. So what we'll do, if you're happy and touch your nose and then clap 3 times. If you're happy and touch your ear. Is that okay? So you all will do with me? Okay. Jaya, your son wants to do with us the same activity? Okay, go ahead. So keep your hands free. If you're happy and touch your nose. If you're happy and touch your chin. Now we'll do it faster. Ready? Okay. If you're happy and you know, touch your ear. If you're happy and you know, touch your nose. If you're happy and you know, touch your ear. How many of you touch your chin? Because more than listening to me, you were observing. So what you do is seen more than what you say. We normally think people are not able to see, from our action. But actually, see at home also, when you tell your children to do something or not to do something, they'll immediately tell you, "आप तो करते नहीं है, आप मुझे कैसे कह रहे हैं?" Because if we are not following the rules of the game, they will not follow. So one of the ways to bring change in the behavior is you have to do what you want others to do. And if you just keep saying, do this, nothing will happen. But if you really do it yourself, you will see mirroring is a very, very powerful way to bring change in people's behavior. People are, more than happy to mirror you, but provided you stick to the behavior that you want. So body language includes everything, right from facial expressions, eye contact, gesture, posture. We'll touch upon each one of them briefly. For example, what are our usual facial expressions when we are, interacting with the patient or their family member? Number 1, 2, 3, 4, 5, 6. Which one? Number 5. Where are others? Number 1. Okay, Dr. Bide says number 1. 9 a.m. number 1. But when the day passes, number 5. Mariam also says number 5. What do others say? Write in the chat box. Maybe we'll get to know. Okay, Neha says number 1. So 9 a.m. Yes, number 1. Seema ji says number 5. Okay. Satyapal says number 1. Satyapal सुबह 9 बजे, 10 बजे, 11 बजे के बाद नहीं. Okay. Okay. Anas also says 1. Dr. Priyanka also says 1. Nivedita says 5. Okay. So number 5 में क्या है? What do you see in number 5? What expressions are they?
He's got a blank face.
Blank face. And when we keep this space, what do we want to communicate? Okay.
When I'm not in
calm, neutral. कहाँ से calm दिख रहे हो भाई? Number 5 कहाँ से calm दिख रहे हैं? What do you want to communicate when you, yes, not interested? Not interested. Why do we keep that face? There's a reason,
exhausted.
Would you like to be treated by a doctor who has this expression or a nurse who has this expression? Will you be happy?
Madam, actually the expression is tiredness, I think so.
वो आपकी इंटरप्रिटेशन
के भागदौड़ में
निवेदिता वो आपकी इंटरप्रिटेशन है क्योंकि रात के 9:45 हो गए हैं तो आपकी इंटरप्रिटेशन बहुत जस्टिफाइड है बट एक्चुअली जो एक्सप्रेशन है ना वो है नो एक्सप्रेशन blank face and we keep this expression when we are talking to the patient or their family because we don't want to make connection with them. We think if I will smile patient will come closer. So we keep a expressionless face, keep away. Don't dare come closer to me. We want to maintain distance. And I asked you, would you like to be treated by a doctor who has this kind of face expression? No. We fear that if we have this smiling face, patient will try for secondary gains. It's all right to have smiling face, but if the patient tries for secondary gains, we can assert. If patient tries to take advantage, tries to, get some extra mileage from you, you can always assert. You can say, no, that's not in my prerogative. But for that reason, we don't have to have an expression which is almost like expressionless. So expressions like anger, irritability, unhappiness, your attitude, they're all visible. They're all visible. You saw that first video. He never said, I'm angry and I'm irritated and I'm unhappy and I have negative attitude. But from his body language, you could make out the facial expression he had, the eye expression that he had. Everything indicated that he was not happy being in that conversation. So check your expressions. What kind of expressions do you have when you are dealing with your patients? So let's do a small, activity. I want you to see if you can really identify the emotions. So I'm taking you for a quiz. As I said, we'll be using a lot of pedagogies. So I'm taking you to a quiz, and I'm going to show you an expression, and I want you to write in the chat box what do you think this expression is. Now, this expression is, what is this? Embarrassment, fear, sadness, surprise. Write in the chat box. Okay, Mariam says embarrassment. Okay, somebody says fear. Again, fear, embarrassment. Okay, 2 embarrassment, 2 fear. 3 embarrassment. Okay. Further, fear. Okay, equal. Embarrassment. So most of you are saying embarrassment. Okay, I'm going to submit this and see. Let's see. Are we incorrect? This is an expression of fear. Okay, going to the next question. See, it's very important to be able to read facial expressions. Not only have the right expression, but we should be able to read others' expression also. Now, this face is expressing what? Flirtatiousness, interest, happiness, politeness. Okay. Dr. Priyanka says happiness. What else? Happiness. Okay. Lot of happiness. Okay, I go with majority, happiness, and let's see what happens. Correct. Good. Happiness. Let's go to the next question. What about this one? What do you think this expression is? Sadness, pain, anger, disgust. Anger. Okay. Anger. Okay. I go with majority.
Disgust.
Okay. But majority says anger, so I'm going with majority because I have to go what everybody says. Okay. Anger. Correct. Going to the next question. What does this expression say? Embarrassment, sadness, amusement, shame. Hurry up. Okay, amusement. Okay, 2 people say amusement. What about others? Amusement. Okay, amusement. So most of you are thinking it's amusement. There I go with all of you and we submit it. Incorrect. It's embarrassment. So I think this quiz was just to make you familiar with the idea that we should be equally good at reading expressions. Because not only that we need to have right expression, but we should be able to see expression. Now coming to the next part of non-verbal communication or body language, eye contact. Making eye contact, we all know, is very important. But what is the protocol? For how long should we look at a person? For how long?
As long as he's talking.
As long as he's talking. Okay.
Yeah, you are communicating with him, so we'll talk with him.
Okay. Any other guess?
I second, madam, also I second it, that as long as you communicate with them, you should be in eye contact.
Again, if you are continuously looking at some person, how do you think that person will feel? Even if that person is talking to you and you are attentively listening. As we need to make notes also, so we have to.
It depends upon whether
the person.
Okay. Yes,
it depends upon where you are talking one-to-one. Then you have to look at the person. If you are talking in the public, then not more than 15 to 20 seconds, look at one person. Otherwise, that person will.
It is a very long period, Dr. Bide. If you will try this, the person will suddenly become very conscious of it.
Yeah.
So the protocol is, when you look at the person, one is in professional setup, we look at the eyes and above the eyes. That's one thing that we have to remember. In personal relationship, we can look at the eyes and below the eyes. And at the same time, look at the person for 2 to 3 seconds and then shift your focus and then come back. Come back. But if you will continuously look, the person will become uncomfortable. And never ever look at the person from head to toe in one go. The person will become very, very uncomfortable. So we have to make sure that we don't, look at somebody for longer than 2 to 3 seconds at a time. In this, there are two postures, A and B, which is okay. Which is okay. A or B? I can see some answers in chat box. B, okay. B. What do others say? B, B.
A.
A, okay. Somebody says A. Actually, both are not okay.
Both are not okay.
Both are not okay.
There's something wrong in them.
Yeah. In A, the person appears
very casual and not interested.
Not interested. And in B?
The second is closed.
Closed. Again, not interested.
Not
And
interested.
has already made up the mind. So, the right posture is when you lean forward towards the person, and that shows that you are trying to build connection with the person. So that encourages interaction. Okay. Touch, we all know in healthcare we need to touch the patient. That's unavoidable. But at the same time, we have to remember that on one side, it can communicate empathy and understanding. But on the other side, imagine for the patient, it's a very uncomfortable feeling being touched by a stranger. So it's very important to remember that it's not a comfortable feeling being touched. So we have to be very careful when you're going to touch the patient. Always touch the patient with care and respect. A lot of time you will see your staff holding the patient, little, I don't want to use word rough, but maybe little tight. The family and the patient feels that I was not touched respectfully. So we have to really be very careful. Before you touch the patient, signpost. What do we mean by signpost?
Tell them like what is going to happen. Just
exactly. I need to check your temperature, or I need to check your pulse. So may I? So you are signposting and you're seeking permission. We normally think if the patient has come for treatment or consultation, there is implied consent. But please remember, implied consent, the patient does not know. So it has to be communicated to the patient. The answer will be yes, but it gives an opportunity to the patient to say no if they don't want to be touched or checked by somebody. So asking them, I need to check your eye or your throat. May I? Is it okay? The patient can say no if they are not comfortable. So before we touch the patient, it's important to inform them and also seek their permission. We all know soft touch on the shoulder or on the head or on the forearm is a good way to communicate, compassion and empathy. But at the same time, we also know that now it is no more considered a very, desirable kind of a gesture. So one has to be really very careful. Unless you have wonderful rapport with the patient or their family member and there's already trust built, then it's a different thing. But it is good to avoid, especially with the opposite sex person. If you're a male therapist and a female patient, it's better to avoid touching unnecessarily because it can create some misunderstanding and we should be careful about it. Hand movements. So which hand movements are not okay? Can you think of some hand movements that you think are not okay?
This finger pointing is bad.
Absolutely. Showing finger is not a good idea.
Yeah.
And what else?
Waving person off is also not good.
Okay, that's also not good. What else? So pointing to the disease part is also not a good idea. If you show your finger to a particular part of the body, it's uncomfortable. So hand movements like this, what can I do? That's not my job. That's your problem. Again, not a very good idea. Or when you want to stop somebody from talking and if you show your hand like this, again, not a good idea. You get out of this place or you come here, again, not a very, very good, hand movement. So we have to be more careful. A lot of time, even this can be reason for conflict between you and the other party. So we have to be very mindful of the hand movements that we make. Okay, so what do you see in this picture? Who is he?
Tattoos.
Importance of proper dressing for a doctor.
Very important, especially for young doctors. I would say that we have to be very, very careful about the way we dress up. Because a lot of time we think it's all right. I mean, we are young and we can wear the way we like. But please remember, you are treated the way you look. If you want to be respected like a doctor, then you need to look like a doctor. Only then your patients will, respect you. And also, they are literally handing over their life in your hands. So you need to have that kind of appearance where they trust you as an experienced doctor who can manage difficult situation. So people normally, from your appearance and your dressing, they kind of, judge your professionalism and intelligence. So we have to take it very seriously that we appear professional. We see young doctors a lot of time wearing, slippers and tight clothes and high heels. Again, you have to remember that people are observing you and then they form opinion about you. Yes, Dr. Priyanka, you want to say something? I believe.
Because not all of us are doctors in the group. I think anyone working in the hospital has to be looking very professional. You don't need to wear very expensive clothes, but you have to, because people do observe that.
It is for everybody. It's thank you for bringing that up, but it is for everybody. Because people are constantly, looking at us, and then the way we appear, that's how they are going to treat you. So even, clothes like very bright color clothes, again, in your personal life, you can wear what you like. But I think in a healthcare setup, we need to wear clothes as per the mood of the hospital, not as per our will and wish. I think 3 questions can help us find the right clothing for us. One, does this clothing fit me properly? A lot of time we see people wearing very tight or loose or short clothes. Again, I think we have to, remember that in a healthcare setup, you really need to run around a lot. So your clothes should not be either too tight or loose or short. Then are these clothes comfortable? If you're not wearing your clothes or your shoes that are comfortable, you will feel tired and exhausted, during the day. And then, am I dressed appropriately for my role and responsibility? If you want your patients to kind of, respect you and trust you, then it's very important to look like the one so that they respect you. So how much of space do you think we need to maintain with people when we are interacting with them? Everybody likes to maintain a safe distance. So how much of distance do you think is okay in healthcare setup or in professional setup?
2 feet.
Around a hand's distance, which is almost like 2 feet. You're right. So 2.5 feet is a good distance to maintain with the patient, because in case you need to go closer, and you will have to go closer, especially if you're going to examine patients' eyes or throat or ear, or even, use stethoscope, you will go closer. So it's very important again to signpost them and seek permission before. Dr. Neha, I think your device is on mute. Unmute. If you could mute your device. Yeah. So I think this is a very important thing. A lot of time patients feel uncomfortable if we are physically very close to them and without any information, without any kind of signposting, they feel uncomfortable. And it's not just for us. I think all staff members should know that this distance has to be respected. While examining patients, while even collecting details, it's important to respect patients' privacy and confidentiality. You will come across situations where patient being examined, especially in government setup, where you don't have proper curtains and guards, and you are just doing the procedure or examining without a much proper covering. Patients feel uncomfortable. I think if we put ourselves in their place and kind of, see how one would feel, we would understand it's not a very comfortable idea to be in a public place and being examined by a stranger. Another important part of non-verbal communication is time management. And when you don't value your patient's time, when you make them wait, when you make them come again and again, they feel that we don't value their time. Again, that's part of your professional conduct. Making them wait and making them come again means additional burden on you, additional work for you. So make sure that you don't, first of all, make them unnecessary. If you really need to inform them how much time approximately it will take. If you have made them wait, it is better to get the work done so that they don't have to come again, and minimize the number of visits to the hospital. So I think whatever we have discussed, all in all, the idea is that there should be a display of respect and care at every point of contact. It could be at the front desk, it could be in radiology, pharmacy, lab, wherever. We have to remember that we have to value patients' time, we have to be respectful, we have to talk to them in a more responsible manner. And that questionnaire that I gave you, I mean, I wish we had time. I could have. I will be showing you this, the summary of what we have done. But if those 20 basic points can be looked after in your conduct with your patient, trust me, most of the things will get covered. Those 20 points that I have, shared as a questionnaire to you, the answer is within those questions. If you remember them, your patient is bound to go back happy and satisfied with you. So I think these non-verbals we should always avoid when the person is talking or saying something. If we start looking away, or we start staring, or you look sarcastically, I've seen people closing their eyes. That means they are showing that we are not interested in listening to what you are saying. But if you can't do that, then sometimes I've seen people using unpleasant tone of voice, or they start doing something indicating that I'm not listening to you or I'm not interested to you. I think one golden rule that we can all practice is, please don't give the behavior to others that you don't like to receive. We all know the basic courtesies. We all know the right behavior. Not that we don't know, but we don't give the same behavior to our patients or their family members. So one golden rule, if we apply, that we don't, give the behavior that we don't like to receive, most of the things will be looked after, will be taken care of. So this is in nutshell about the 3 parts of communication: verbal, and then tone of voice, and the body language part. Any questions about what we have discussed? Anything you wish to ask or say?
So we have sent the Google form. You
Yeah.
can send.
Yeah. So I'm going to show you the reading. See, for most of us, we have said most of the time or sometime. So when we are saying most of the times, that means there is still a scope to improve. And when we are saying sometime, that means there's a huge scope to improve, isn't it? So I'm just going to show you the summary of what we have all answered. Not all of you have answered. I think I have received 11 responses in that. So I'm not going for the individual answers, but I just share this summary with you to let you see that even basic things we are not actually following. So I've received 11 responses, and then let me, yeah. Give me a second. Why is it saying not? Yeah. Yeah, there we go. Mhm. It's taking a little time to reload. Give me a second, please.
जान 5 मिनट और रह गए
Really sorry, I don't know why is it not loading chatting. Let's see if it works this time.
अनज व्हाट्सएप करके पूछ रही है कब खत्म करेगी.
कोई म्यूट मोड पर नहीं है और आपकी बात सुनाई दे रही है. आई डोंट नो हु इज दैट. सत्यपाल बस 5 मिनट और. आई नो यू मस्ट बी टायर्ड. I think we'll discuss this in the next session because it's taking time to load. If that's okay with all of you. Try once again. Yeah. Yeah. Quickly we can have a look. See, for simple things like do I greet the patient again? Almost 63% of you have said always, but again, almost 40% of you or 35% most of the time. That means we are not practicing these simple things even, with all the patients. Now going down, a couple of things that I observed, like from question, okay. Now addressing patients' emotional issues. Again, 18% of you have said always, but almost 81% of you have said most of the times. That means we are not actually doing it for all the patients. And then when it comes to explaining the patient in an understandable manner, only 27% of you have said always I explain in an understandable manner. But again, 50% of you or 55% of you say most of the time. And again, 20% of us have said sometimes. That means I am not explaining in a understandable manner. So same way for most of the questions I see some of you have said always, but a lot of you have said most of the time. So that means it is not 100%, but we are. The idea of giving this questionnaire to you was to give you tips for what is basic in your communication, what is required in your. If you can just integrate this, you will see a sea change in the patient satisfaction and even in your satisfaction. So the things are very, very simple, but again, some of us are not even following that. Any questions about what we have discussed?
In the current scenario, we are using EMR quite a lot. And most of the times when we are taking the history, we are entering the data there. So many times eye contact gets lost. So in between, I always take a pause and look at the patient and see his response. But like initially when we were not using the EMR, that time it was a very, all the time we were connected patients. But EMR has got definitely some advantages, but this particular disadvantage I find it with it.
So there are two things that I would like to mention here. Thank you for bringing that up because there are a lot of articles that talk about third person in the room. That means there's a proper person. So the whole idea is one, if you inform the patient that whatever you are saying, I need to make a note of it so that I can I don't miss any vital information. So the patient first of all is in the know of it that it is patient's record that we are entering simultaneously. So they are okay with that. That is one thing. Second is we make frequent eye contact in between so that we just don't do it mechanically, but we are making enough eye contact so that patient feels that I am being heard. And third, in case if the patient is sharing something very sensitive or you think it has some emotional content, so you feel the patient requires your attention and your. So for those couple of seconds, one can stop writing and one can, look at the patient and then complete that loop and then move on to activity. Only thing is if we are mindful of the fact that we have to make eye contact. That thing we have to remember. That's it. But thank you for bringing that. Yeah. Any other comment or feedback or yes, Mariam?
Yeah, how to deal with the language barrier especially when we're not fluent, because we make a lot of grammatical mistakes when like we know like a little bit of the language but we don't know the nuances of it. So how to deal with that?
So I think one is that hospitals should encourage having, staff who know the local language. For example, if I am new to that place, but if I have people who know the local language, they can be of help to me. And usually I think hospitals try to have a mix of, staff so that they can cover multiple languages. But then if I am coming to a new place as a, employee, then sooner I learn the local language, better it is for me. And especially if I'm going to stay there, then I have to learn the local language. Otherwise, there can be a huge error just because of this. Now, for example, if your patient says कि इसको चमकी हुआ है या चमकी होता है, what is the meaning of that word, चमकी? And if you miss that, you miss the diagnosis. It's very important to really know the local language. And then in case if no communication is happening because of the language missing, then please have somebody, call somebody to, intervene for you and the patient, and then do the complete communication rather than just assuming that I'm understanding it right. It should not be left unaddressed.
Okay, thank you.
Thank you. Any other question or? So if there are no questions, we'll close it here, and I will post the feedback form in the group. I request you to complete that feedback form. I read every feedback very carefully. Last time I received only feedback from 9 of you. I request all of you to take out those 2-3 minutes and complete the feedback form, because based on that, I try to change or modify the next session so that I can meet your requirement. So I request all of you to complete the feedback form maybe in next 24 hours. That's also okay. Yeah, Priyanka has written that she uses Google Translate tool. I think that's also a good idea. I'm not sure how much of accuracy you would get into that, but if you're using it and if you're okay with this, this can definitely be recommended to everyone. Yeah. Thank you so much. I'll not hold you further. Good night. Take care. Bye-bye.
Thank you, ma'am.
Thank you, ma'am. Thank you, everyone. Good night, everyone.
Good night, all of you. Yeah.
Thank you. We are meeting next Thursday.
Good night.
Next Thursday, that's right. Yeah.
Thanks to all.
Unless you want to have 2 sessions next week.
We can have 2 also. Can have 2 also.
Is everybody okay with that? Okay, yes. Maybe I'll put in the group that can we have 2 sessions on Monday and Thursday. And if everybody agrees, I'm okay with that.
Thursday.
Yeah, Mondays, not Monday. Monday.
Tuesday
okay.
and Thursday.
Tuesday, no, but Tuesday, Dr. Priyanka cannot join.
Okay.
Yeah.
Any
I
2
think
days.
it can be Monday and Thursday, otherwise only Thursday. Okay. Thank you so much. Good night.
Okay. Thank you, madam.
Thank you, ma'am. Thank you.
Thank you.
Thank you, madam.